In today's video, we will go through a cataract surgery. I will go over kind of what's going through my mind as I'm doing the surgery and kind of just review it like we are reviewing sports film, basically, because it's the same thing for a surgeon. So let's get into the video. What is up, guys, and welcome back to the channel. I'm Zach with Dr. Eyeball MD. It's good to have you back. If you're new, I'm a third-year ophthalmology resident, learning to do cataract surgery, learning to become an eye surgeon, and soon will be starting an oculoplastics fellowship. I have done less than 100 cataract cases at this point. I have a bulk of my cataract cases left to do in the last 2 to 3 months of residency. That's where I get most of my cases, hopefully another 100 or so. Ideally, COVID kind of hit the numbers a little bit, but still getting a fair amount of cases. So take what I say with a grain of salt here. I'm not an expert, but I think it is good to kind of review your cases in the same way that, a college athlete would review their sports film and go over things that they did well, things that they need to improve on, and learn from it. Because despite being there and doing the surgery, you can't really process it all and think about it all in real time. So it's good to go back and actually see yourself from a third-party kind of point of view and see what you were doing well, see what you weren't doing well, because sometimes it looks different on the video than it was playing in your head. So in this video today, I'm just going to go through an actual cataract surgery and show you kind of what I'm thinking, and hopefully it'll help some people out there, especially if you're a new or novice resident surgeon learning to do surgery. Thoughts, basically, for somebody also in your position. So let's dive into the video. All right, so let's start the case. Notice first that I've marked the eye for a toric. We're gonna place a toric lens on this. So those little purple marks are the axis that I want the toric to be on, or the axis that I want the toric markers to line up with. So we've marked the eye. If you can look infranasal, you'll actually see there's a little blood down there. That's from the subtenon's block. So that's what that's from. So go ahead and start. I've sped this up for time's sake. So right here, just starting off the case, I'm using a 0.12 forcep here at the limbus and then the super sharp blade there. And making that, I like to make that initial incision basically at the limbus. We get a little nicking of the limbal vessels. It helps it heal. It's probably not so necessary with the paracentesis, which is that wound, as it is with the main wound. But trying to make that incision parallel or just slightly steeper than parallel to the iris, so the plane of the iris when we go in with that blade, that'll help it be a little shelf and self-sealing. Now using the 0.12s to basically stabilize the eye on the opposite side of where I'm going with that blade, that may be a little uncomfortable under topical, so keep that in mind. This patient's had a subtenon's block. Going in now, we're going to use a little trypan blue. This is a blue dye to stain the capsule. So see, even though that was sped up, it was very quick. That injection can be really quick. It doesn't need to take a long time. So going in through that paracentesis, just beneath the lip, essentially. So if this is kind of the opening, or if this is the opening of your paracentesis, basically just sticking it in perpendicular to the wound and just under the lip. It doesn't have to enter all the way into the AC, into the anterior chamber. So just inside that lip and quickly injecting, and it will fill it up with a little trapdoor technique. We give that dye a little bit of time to stain the anterior capsule. And so just checking the pressure, and you can burp it down, you can burp the paracentesis a little bit if the pressure is higher than you want. And we'll let that sit for about a minute. That can vary depending on how stained you want the capsule, really. But we'll let that sit for about a minute. And once the capsule's stained, it'll go in with either episugarcane, so like epinephrine and lidocaine combo, or just VSS solution and rinse it out. When we go in with that cannula, you go in more parallel to the iris and actually get a little bit in the AC. So moving back a little bit, notice the cannula there is parallel, and it's not that far in. It doesn't have to be all the way in the eye, it just needs to get inside a little bit. And then rinsing out that blue, trypan blue dye. And you can see it reflux out from underneath the iris there. If you watch again, you can see it it seeps out from underneath the iris right there. And so sometimes I'll actually burp the paracentesis a little bit just to kind of get that to come out, and then I'll rinse it a little bit more. But that's probably plus or minus. You don't really need to do that or have to do that. But I'm just trying to get the blue out of the eye. Then we're going to go in with the viscoat cannula. So this is the viscoelastic, the dispersive viscoelastic, to coat the endothelium and kind of plump up the AC so that we can operate within the eye. So this going all the way across the AC, be careful you don't hit the capsule there, and then kind of pulling back get the eye to a good pressure, feel it, make sure it's a good pressure. And then we're gonna go ahead and make our main wound incision. Now, with the main wound, if your pressure inside the anterior chamber is too high, you're gonna tend to make a shorter wound, whereas if it's too low, the wound will tend to be a longer wound. So we want a good physiologic pressure, but I do tend to have my pressure normally a little higher than physiologic, I feel like, and my wounds tend to be a little on the shorter side. I feel like it makes it easier to operate, and I have yet to have one leak at the end of a case, so I think I prefer a little shorter than a little longer. So at this point, we're gonna go in with the 0.12s, and I just use them to kind of stick them in the para there to stabilize it basically, and then I'm gonna use the keratome to make a triplanar incision. Note we're out at the periphery of the limbus here. This is not a true clear corneal temporal incision because I'm nicking those limbal blood vessels. I'm going a little more peripheral. That'll promote healing and better sealing of that wound. And so it's gonna be a triplanar incision. So we dig in a little bit going parallel to the iris, and then angle down about 25 to 30% of an angle between the bottom of your blade and the eyeball. So like the sclera, the blade, and the eyeball, that angle, about 25, 30 degrees. And then traveling up through stroma, so entering parallel, turning, traveling up through stroma, and then turning back parallel to enter, parallel to the iris to enter into the anterior chamber. All right, stabilizing the eye again, just because she was moving around a little bit. Despite the subtenon's block. Then I'm going to go in with the cystotome. Ideally wouldn't have to use a cystotome, but here I am using the cystotome, which is just a bent needle, and using it on a coaxial setting so it gets a good red reflex, and kind of just starting that rhexis. It's a little baby rhexis basically, so I don't make it real big. You could, ideally would go further out and then push it up to make it bigger, but I'm just going to spiral it out a little bit just to make sure that we don't run it out in the beginning. Okay, so I made a little flap with the cystotome. Ideally I would make that bigger. I made it just a little baby flap, and then I'll just spiral it out here in a second. And then I'm gonna go in with the Utratas and basically grab that flap and take it out to about the size that I want, and try to pivot in that incision. And now I'm getting the rhexis out to more of a size that I want it, and I'll spiral it out so that it looks the way that it should, and you know, it's more circular, and about like that. So decent capsulorhexis there. And then go in for hydrodissection. So making capsulorhexis, I think it would be a little easier looking back to maybe make it bigger from the start and not have to spiral it out, just being a little extra cautious. So I didn't want it to run out on me or anything. Hydrodissecting here, going underneath the capsule there, and being relatively cautious just because can't really see the fluid wave because of how dense this lens is, and so I don't want to blow out the posterior capsule by over hydrodissecting there. Normally I would rotate the lens, but I must have seen it come forward during the case and figured that it was probably going to rotate. So now going in to actually do the phacoemulsification, I'm going to use divide and conquer technique here. So I had to fix the sleeve there, but because it was put on wrong, I think initially. So just grooving. Those first few passes can be fairly deep. They don't have to be too cautious. When you get a little deeper, you wanna be a little more cautious so you don't go too deep. And then I just watch those ridges, watch for the red reflex coming through. And I probably could have gone a little deeper there, but I just wanted to crack, and I know this is such a dense nucleus that it's not going to be super difficult to crack, that I don't have to go crazy with the grooving here. So spinning it another 90 degrees, and I'm just going to go ahead and make the full cross so that it'll be easy to get this into quads, and I'm not going to try to bring this out as heminuclei. So at that point I've got a cross. Now that could be deeper. You can see it's not like a huge red reflex coming through, but as long as I can crack it, and I'm pretty confident at this point that it's going to crack, then it's fine to just go ahead and give it a shot, give it a crack. So this is a Drysdale. It's basically a little spatula, and I'm going to use that. I like it because it has a lot of surface area for pushing. So going in with the 2, diving deep with that phaco tip, that phaco probe, and then sneaking the Drysdale in with it, and going deep in the crack and far out peripherally in the crack to split. You just have to think about the physical forces that are at work here, the vector forces, and how it's going to be more likely to split if you're out peripherally and deep. Just the physical forces that you're placing on it are going to be more effective than if you're in the middle trying to break a circular, a circular nucleus. The forces are just going to be easier and more favorable if you're out further and deeper. So it partially cracks there. I spin it and it partially cracks. So at this point I have a quad spinning it around, and this is going to make another quad as I split it, and then once more splitting there, and just using the Drysdale to kind of rotate it around. So at this point, coming out with the Drysdale, probably didn't have to do that, but I did. And so I'm going to take out those first few. I'm going to go to the quad removal setting and just try to eat them within the iris plane. I don't want to be bringing this up and banging it against the endothelium or phacoing so high that we're going to cause a ton of corneal edema. So trying to eat that within the iris plane. And then taking that second one, your bag is really not going to come forward while you have the rest of the nucleus in the bag, keeping it back. So you worry about that a little bit more with these last couple pieces. So spin it around. That's why I go back in with the Drysdale here and use it to kind of prevent the bag from surging forward. Now with these new phaco machines, the risk of surge and things are less, so you don't get that as much. But being cautious there, using the Drysdale as kind of a protective instrument to keep the bag from flying forward and hitting the phaco tip so that it doesn't rupture the bag. And just eating that last nuclear piece. And once it's out, come out with the Drysdale or the second instrument first. In case the anterior chamber collapses, if you pull the phaco tip out first, your anterior chamber collapses and then your bag could be punctured by your second instrument. So tend to come out with the second instrument first while the phaco handpiece is still in the anterior chamber, irrigating the eye, maintaining the pressure within the eye. And then once the second instrument is out, going ahead and coming out with the phaco instrument. So there's wispy cortex left. These dense lenses will sometimes leave wispy cortex and don't always leave behind those big sheets of cortex. And so we're going to do some cortical removal and just using kind of like a hurricane technique or like a radial pulling technique to do that. These little adherent pieces left, I just switch to a polish setting and then kind of try to polish those off. And then you can go and polish on the underside of the anterior capsule like I'm doing right here, just to try to get rid of that kind of extra material that's on the back of it. Try to reduce the chance of it phimosing by leaving all that there and contracting down later. They've had to do YAG capsulotomies, like radial YAG capsulotomies to release those before. So going in now with some Provisc, you want to go in and fill the chamber and then dive a little and actually fill the bag up so that you have a place to put your lens. So diving down with that cannula, Provisc, and filling up the bag. Now, because the incision that we made with the keratome initially was a 2.4 or 2.4 millimeter incision, it's a smaller one than the 2.7 or 2.75 that we have sometimes when we use a larger keratome. And so when it's a smaller incision, sometimes this injector doesn't want to go all the way in the AC or all the way through the wound. So if you just get the lip of it underneath the lip of your main wound incision and place good horizontal traction against it, like I'm doing here, you can see the eyes rotated away, and then once the lens is halfway into the anterior chamber, I'll pull back to primary position as I inject the rest of it, and there you can see it's in the bag. Now going in with the Maloney and actually rotating the lens, putting the haptics in the position for the toric. Now, if we're not doing a toric, or even if we are doing a toric, you really can do this part with the IA handpiece when you go in to remove the viscoat. I feel like, especially if you're doing a monofocal lens, going in with the Maloney and kind of like spinning it around, and it's really not necessary, especially if you inject it into the bag. Even if the trailing haptic is not completely in the bag, you can use the visco or the eye handpiece when you go in for viscoat removal to put the lens where it needs to be, and you can rotate it with that and save yourself a step of going in with the Maloney to recenter it. But I'm using the Maloney here because I want to dial in the toric to be in alignment with the toric markers. So it's a little under-corrected there, and I did that on purpose so that if it moves at all once I remove the viscoat, I don't want it to over-rotate because it's harder to rotate it back counterclockwise So it'll be a little easier once I get the viscode out to just dial it into the correct position clockwise, because just because of the orientation of the haptics, they want to spin clockwise and they don't want to spin counterclockwise. Here going in behind the lens, so you can see that the phaco handpiece, or the eye handpiece here, is behind the lens, and I'm making sure that we get out all the visco from behind the lens. I think you need to know how to do that. Now, is it always necessary? Probably not. You're more or less gonna get it. It's gonna come around from the back of the lens. Either way, typically, especially if you push down on the lens a little bit with the eye handpiece, you can kind of scooch it out of the way, and the visco or the provis behind it will normally come around. But here I'm just going behind it to make sure that we get it all, because that acrylic optic is sticky to the posterior capsule, and you want those to stick so that your toric lens is not rotating around. And so that's why I'm doing that. And so then once I get it all out, I just bring the optic back, and here kind of rotating it with the eye handpiece a little bit to get our toric markers in alignment. And they're still a little bit under corrected at this point, so I'm trying to dial it in a little bit here, and I'll go back in with the Maloney after I hydrate this wound. Now, the way to hydrate the wound is, I don't know, I guess a topic of debate, but I prefer to just do a small amount of hydration on the roof of the main wound incision. But here, I think just because of the staff I was with, they wanted me to hydrate a little bit more tangential and like on the side of the wound, which if you just think about the physical forces at play, when you hydrate that main wound, doing it on the side maybe swells it a little bit, but I just don't know that it makes the most sense. So I prefer to just do very light hydration on the roof within the stroma of the main wound. You just have to be careful not to detach decimes when you do that. But here I did it in a way that I normally don't. But getting the eye at a good pressure here, and then actually going back in with the BSS cannula, just making sure that we're dialed in. And so I guess I didn't go back in with the Maloney. I got it in position with the BSS cannula there. And if you are going to go in with the BSS cannula to recenter or reposition the lens, if it's trying to prolapse out of the bag, or anything, if the optics are prolapsing through the bag, just inject BSS solution as you're in the AC. Keep injecting, and then you can manipulate it with the BSS cannula, and then as you come out, keep injecting so that the AC stays formed and the lens doesn't want to prolapse forward. And just using a little bit more here, I guess I'm trying to center it a little better. But remember, perfection is the enemy of good, or something like that. So at some point, just you gotta say this is good enough, because you can't overdo it. Making sure the wound's hydrated a little bit more, hydrating the para, and then just making sure that our wound is sealed, self-sealing incision, don't need sutures, checking the pressure, and we're good. That's the case. Now, it was not the fastest case. It was not using any fancy techniques. It was a very dense lens, and so I just went with an old tried and true divide and conquer. So basically, that is just kind of a cataract surgery that I did as a resident. So obviously not a perfect case, but I think there's something to be learned from watching it at different levels. And also I think there's definitely something to be learned from watching your own cases. So you really should be reviewing your films and your surgeries and seeing where they can be better and where they're already good, and make sure you're focusing on the right things that you need to focus on. So that's why I watch the videos, to make sure that I can get better at it. Anyways, I hope that was informative and helpful. Maybe it helped some people out there if you're already a practicing cataract surgeon. Maybe you're laughing at me, but maybe for some people coming up or about to start learning cataract surgery, it will be a little bit helpful to kind of go through some of the thought process and hear at least somebody not so advanced as cataract coach kind of talk about it, because that guy's so freaking good that I think it can be a little hard to relate sometimes to the way he operates, because he's just very, very good at it. So anyways, for somebody that's done less than 100 cases, maybe that's a little more relatable to some of you newcomers. Anyways, if you liked the video, leave a like on it, subscribe to the channel. I'm Zach with Dr. Eyeball MD. I will see you in the next one.